Welcome back to the Ninja Nerd Podcast. Today we're talking about vasculitis. There are a ton of them to talk about. Let's not waste any time. Let's get right into it, Zach.
Let's do it, buddy.
All right. So case one, we're trying to diagnose this type of vasculitis. So listen carefully. There's going to be some buzzword terms. You might know what we're talking about. So we have a 70-year-old female presents to the ED with complaints of severe headache, jaw pain, and visual disturbances. The patient reports a 2-week history of a new onset severe throbbing headache, predominantly located over her right temple. She describes the pain as constant and worse at night. She also reports pain in her jaw when chewing food and a sudden onset of blurred vision in her right eye over the past 24 hours. She denies any trauma, nausea, vomiting, or previous episodes of similar headaches. Additionally, she has been experiencing generalized fatigue and unintentional weight loss over the past few months. Vitals: blood pressure is 145/90, heart rate is 92, respiratory rate is 18, temp is 37.8 Celsius, and her SpO2 is 98% room air. On her exam, head and neck, there is tenderness over the right temporal region with a prominent pulseless temporal artery. Right away, Zach, what are you thinking?
Potentially like giant cell arteritis is kind of what I'm looking at here.
Okay, let's keep going. For her eye exam, reduced visual acuity in the right eye. MSK, limited range of motion in the shoulders and hips due to pain. Her lab testing, erythrocyte sedimentation rate, ESR, is 85, which is elevated. C-reactive protein, CRP, is 7.5, elevated. Her CBC is only notable for mild normocytic anemia, and her CMP is normal. She does get a couple additional tests, but we're waiting on results back, and that would be a temporal artery biopsy. So, Zach, what are we thinking here? How do we go about approaching this case?
So vasculitis is a difficult diagnosis. I think you have to have a high degree of suspicion to kind of suspect vasculitis. What I would say is when you have a patient who has some non-specific symptoms, for example, some generalized fatigue, fevers, they have some weight loss, anorexia, things like that, and on top of that, they have an elevated ESR and CRP, I would be like highly suspicious potentially for vasculitis, especially if they have some organ-specific symptoms. So what do I mean by that? Well, first thing I see that she's had some fever, some fatigue, some weight loss, some anorexia, correct? Her CRP and ESR is elevated. The way I like to group these is large vessel, medium vessel, and small vessel vasculitis. So for large vessels, those are going to be the ones that are the aorta and the big branches coming off of the aorta. So for example, in giant cell arteritis, it typically affects the branches off the carotid. So for example, I would see the superficial temporal artery involvement, which I do hear she has some temporal headaches, some tenderness in that particular area, and a pulseless temporal artery, meaning that it's probably super, super narrowed and stenotic, that she's not getting a lot of blood flow through that. I also noticed she has some involvement potentially of her ophthalmic artery. She's got some reduced blood flow potentially to the right eye, which is causing some visual acuity problems in that right eye. And then lastly, she probably has some reduced flow through the maxillary artery. And that's causing some jaw claudication, which is that pain and kind of soreness of the muscles around her jaw when she's trying to chew.
So for her, each vessel is affected.
Yeah, it seems like every single vessel is affected. And the concept behind that is that she's having inflammation, where the inflammation is causing kind of sometimes thrombosis in those vessels or stenosis of those vessels. And so you're kind of limiting the blood flow to those tissues. And so that seems to be her presentation. So with that being said, I could honestly make the diagnosis, I'd say pretty much close to having the diagnosis without even needing the biopsy. And it's actually, I think, very important for your boards and for true clinical world. Don't ever, if you have a patient with visual changes and you suspect that they have giant cell arteritis, don't wait for the results of the biopsy. Start them on steroids first. Start them on steroids to reduce the inflammation of the ophthalmic artery so they don't lose their vision permanently, because that's a lawsuit waiting to happen, and that's a patient's vision loss. All right, so that's really, really important. Start them on steroids, wait for the results of the biopsy as the steroids are cooking on the patient, and then once you get the biopsy back, if it shows giant cells with a lot of granulomatous inflammation, you've nailed the diagnosis of giant cell arteritis.
Now, we didn't get any other imaging for this patient, but would you? Depending on the symptoms she's having, I'm talking CT, MRI, would you do that?
Not for this patient. I would say sometimes there is an ultrasound that can be done. Sometimes they can do like a Doppler ultrasound around the actual vessel and look for kind of like a significant narrowing of the vessel. But oftentimes, no need for any true diagnostic like imaging. I would say gold standard is a temporal artery biopsy, but you can consider a Doppler ultrasound. But I'd say this would be good enough.
Let's move on to case 2. We're still trying to figure out how to diagnose the type of vasculitis. As Zach said, we can try and group them into a large, medium, or a small vessel vasculitis. So this one, we have a 28-year-old female presents to the clinic with complaints of fatigue, weight loss, and intermittent fevers over the past 3 months. So it's constitutional symptoms again.
Exactly.
She also reports onset of pain and weakness in her left arm. The patient describes a 3-month history of generalized fatigue, unintentional weight loss of approximately 10 pounds. Sounds kind of nice. And intermittent low-grade fevers. Over the past few weeks, she has noted increasing pain and weakness in her left arm, particularly with exertion.
Okay.
She also reports occasional dizziness and lightheadedness. She denies chest pain, shortness of breath, or palpitations. I always like to give you a moment. Zach, any thoughts?
Yeah, I mean, this one right here, it seems like she's got, since we're talking about vasculitides in sense, she's got constitutional symptoms, as you said, but it seems like there might be some kind of blood supply, particularly to the left arm, like a subclavian artery or something to that effect, that may be kind of narrowed off.
Okay, let's keep going. Vitals are blood pressure 120/80. However, we do a blood pressure because of the issue with her both arms that we notice. We take a blood pressure on the right arm, 120/80, normal. But then we do it on the left arm, and it's 95/60.
Oh, there it is.
So right there, you have a pretty good idea. Going off of that, Zach, really quick, how would you know to take the blood pressure in both arms? Are you just saying, hey, there's some differences going on, you should be thorough?
Yeah, I think one thing that's tough with this patient, I think like if I were to look at this patient, I wouldn't necessarily go right away at getting a blood pressure. I think in a clinical vignette like this, they kind of set it up perfectly.
Yeah.
But oftentimes when you have a patient with that like ripping, tearing chest pain, or maybe if they present with like limb claudication, which this one's kind of presenting as an upper extremity clinic claudication on one side, that might make you think to say, hey, let me consider checking the blood pressure on that left side and right side, making sure that there's no kind of like uneven or unequal blood pressures or pulses. So that might be one reason, but oftentimes you think about this in patients like aortic dissections.
Okay.
That ripping, tearing chest pain to kind of say, hey, is there any differences or asymmetries in blood pressures?
Because it's a good thought, but not many clinicians would probably jump toward that.
I definitely wouldn't have right away, just off of the initial complaint and,
right.
Kind of history of present illness.
But I guess, if you want to be thorough, then there you go.
Exactly.
So let's continue with the vitals. We have their heart rate, 85. Respiratory rate is 16. Temp is 37.5 Celsius. And her SpO2 is 98% room air. On her exam, pulses. There's a weak radial pulse in her left arm, normal in the right arm. There is a audible bruit over the left subclavian artery. MSK, decreased strength overall in her left arm. Some lab testing, we get an ESR. It comes back as 90, a CRP as 8, and a CBC, again, mild normocytic anemia. And then additionally, a CMP comes back normal. We do get imaging. We get an MRA. That's a magnetic resonance angiography. It reveals significant narrowing and thickening of the left subclavian artery and irregularities in the aorta.
All right.
There you go. So, Zach, at this point, let's just start off with what type of, is this large, medium, or small? And then how do we go approach this case?
Yeah, this one seems like a large vessel vasculitis. And again, that kind of narrows down my differential. I already kind of talked about one, which was giant cell. The other one is Takayasu's. And so Takayasu's is often sometimes referred to as, in quotations, the pulseless disease, meaning that there is some type of luminal narrowing or irregularity within the vessel lumen, particularly affecting the proximal portion of the aorta, like the aortic arch, and then the branches coming off that, like the subclavian as well as the carotids. And so right away, I'm definitely thinking this is Takayasu's. One of the other kind of buzzword terms here is that when you see a patient who's less than 50 years of age, oftentimes of Asian ancestry, that kind of supports the epidemiological clue for Takayasu's, whereas if they're greater than 50 and they're a female, it supports more of the giant cell. It's unlikely to ever have a patient with giant cell that's less than 50. So that right there kind of tells me that it's likely Takayasu's. And then her physical exam, and again, the presence of luminal irregularities and narrowing of the vessels of the aorta and the proximal branches supports Takayasu's pretty much. So for me, elevated ESR, CRP, some constitutional symptoms. Then I'm suspecting it's large vessel based upon the presentation overall. When I see that she has unequal blood pressure and pulses between the right and the left arm, there's narrowing of her subclavian artery. And then she has decreased strength in the left arm, which is because she's not giving enough blood flow to the muscles of the left arm, causing her upper limb claudication on that left side. So that right there would honestly be pretty good if I found a bruit in that area. That also adds some utility, but it also is important to remember that it can hit the carotids. And so sometimes a patient can develop syncope. They could develop, worst case scenario, a stroke. And so that is also important to remember. But for For this patient, the clinical utility for me is her exam, elevated ESR, CRP, constitutional symptoms, and then the MRA suggesting that she has that narrowing of the actual aorta and its proximal branches.
Yeah, I would have to think the MRA is going to seal the deal there for you.
Exactly. And so that's kind of the interesting point between these two, is that when you try to look at them and differentiate them, you can differentiate it based upon epidemiology, greater than 50 for GCA, less than 50 for Takeyasu's. More proximal artery involvement of the aorta, Takeyasu's. More distal kind of branches like the carotids, giant cell arteritis. And then interestingly, their presentation will differ based upon the arteries involved. What's really interesting is their treatment's kind of the same, and that's kind of nice.
Let's get right into that then. So we've talked about giant cell, we've talked about Takeyasu's. How do we then differentiate based upon treatment? Is it very different or is it similar?
It's relatively similar. It's just you're kind of trying to come up with a justification of why you're going to give them steroids, really. So, for example, in giant cell arteritis, if a patient has vision changes, steroids right away. So that's really, really important. And I think that's super important. For example, if they have vision changes, you should start them on IV methylprednisolone. If they don't have vision changes, but you have a diagnosis of giant cell arteritis, you should start oral steroids. And then basically you try to taper them off of the steroids over time. And if you can't, or if they don't get better despite being on steroids, that's when you put them on something like, for example, methotrexate or tocilizumab.
And again, that's regardless of biopsy results. They're having vision changes.
Yeah, so vision changes, IV steroids. No vision changes, but they have a diagnosis with a biopsy result. You can start them on oral prednisone. But again, for these patients, if they don't respond, then put them on those refractory meds. But oftentimes that's it. Sometimes in Takeyasu's, if a patient is having like a really bad limb ischemia, like their fingers are starting to turn blue or discolored, and I'm worried about like actually preserving a limb, then sometimes I will kind of reach out to interventional radiology to go in and balloon open the vessel and put a stent in to give some patency of blood flow. But oftentimes hitting them with steroids up front, and then the immunosuppressants like methotrexate or tocilizumab, if they don't get better, I can't get them off the steroids.
So if they're refractory, that's where methotrexate or tocilizumab.
Exactly.
Okay.
Exactly.
All right. That does it for case 2.
That's it.
Okay. So those are our large vessel vasculitis. If you probably haven't guessed by now, we'll head to the next category.
That's exactly right.
But it's still trying to figure out how we can differentiate and maybe even do a little summary at the end.
Yep. I like it.
So case 3, again, trying to diagnose the type of vasculitis. We have a 45-year-old male presents to the clinic with complaints of abdominal pain, weight loss, and our new rash on his legs. We haven't had a diarrhea case yet.
No, I was going to say that.
Remember our theme.
Yeah, I like that. All right, we're getting to good actual medicine here.
If you guys are watching each one, we've had nausea, vomiting, diarrhea.
No more cases of someone restocking the lake with brown trout anymore. We're moving on to bigger and better things here.
So we have this patient, and he reports experiencing progressively worsening abdominal pain over the past 3 months. The pain is diffuse and crampy, often occurring after meals. He has also noticed a significant unintentional weight loss of 15 pounds during this period. In the last 2 weeks, he has developed a painful purplish rash on his lower legs. He denies any fever, night sweats, or recent infections. Additionally, he mentions occasional muscle aches and joint pains. That purplish rash, you talking purpura?
It could be. It honestly could be.
Levedo reticularis?
Could be one of those two. Yeah.
So either or.
Exactly. I think if this is the disease that we're thinking it is, oftentimes in vasculitides, they can present with palpable purpura as a big kind of trigger. Another one could be levedo reticularis.
That's the one I was trying to think of.
Yeah.
So past medical history. The patient had past medical history of hypertension and a hepatitis B infection diagnosed 2 years ago. Currently not on treatment.
Yeah, that's usually a buzz term right there.
That's the giveaway right there.
Yeah, that's a big one.
Vitals. Blood pressure is 160/90. Heart rate is 88. Respiratory rate is 18. Temp is 37.2 Celsius. And SpO2 is 98% on Romer. For the physical exam, we do an abdominal exam first. There is mild tenderness over the abdomen, but there is no guarding or rebound tenderness. Dermatological exam, palpable purpura, and levedo reticularis on both lower legs.
You said that nicely.
Nailed it.
Yeah.
MSK, mild tenderness in the muscles of the lower extremities. There is no joint swelling. And then for our neuro exam, we have a mild left wrist and right foot drop with a associated numbness and tingling.
Oh, this person's all jacked up.
Yeah, something's going on here.
They got a lot
That's not right.
Nope.
That ain't right.
Something ain't right with this.
So some lab testing. We have a CBC. We get a couple things for the CBC that we know. Hemoglobin is 11.5. The white blood count is 12,000, and the platelets are 350,000. For the CMP, we get a mildly elevated liver enzyme count back, with the ALT being 85, AST being 95.
Okay.
For the ESR, 100. The C-reactive protein, CRP, is 9. And the hepatitis B surface antigen is positive. Anti-neutrophil cytoplasmic antibodies, the ANCA, is negative.
All right.
Some additional testing and imaging. We do get angiography. It reveals microaneurysms and irregular mesenteric and renal artery constriction. Skin biopsy shows fibrinoid necrosis of vessels.
All right.
Zach, what do we got going on here?
This is like a perfect case, man. It's like set up perfectly. But when I see a patient who has hepatitis B virus infection, when you talk about vasculitis, it automatically makes me think about polyarteritis nodosa. So that's one definite thing there. So if I see a patient who has constitutional symptoms, as this person does with the weight loss, the slight fevers and the night sweats and the joints and muscle aches and things like that, definitely makes me think that, again, constitutional symptoms, as well as elevated ESR and CRP. That's through the roof. Their ESR and their CRP is pretty elevated. If I see hepatitis B virus infection, I'm really thinking about polyarteritis nodosa. A couple other systems that I'd like to see involved, though, is the kidneys. So I like to see hypertension. And this patient does have a blood pressure of mine, which is 160/90, right? So it's pretty elevated there. So that definitely supports that they probably have some degree of underlying hypertension. I also like to see skin involvement, which they have both, as you nailed perfectly, palpebral purpura and levator reticular. I slipped up there.
Yep.
And then on top of that, I also like to see neurological involvement. So this was the weird one, is the mononeuritis multiplex. That's whenever you kind of hit the vasa nervorum, which is a blood vessel that supplies the nerves, and they get nerve damage to two or more nerves in the body, like a multiple mononeuropathy. For example, they have left wrist involvement. So maybe they have some radial nerve involvement that's actually causing radial nerve palsy. And then a right foot drop. Maybe they have like a right peroneal nerve that's got kind of injured or it's damaged and it's not allowing for those muscles to contract properly. And then on top of that, there's some associated numbness and tingling. So again, it supports kind of a neuropathy here. So I see mononeuritis multiplex. I see skin lesions. I also see hypertension. I see hepatitis B virus infection. The only other thing is that sometimes it can even cause small little microaneurysms and stenosis of the mesenteric vessels, to where the patient can get mesenteric ischemia, and oftentimes they'll present with abdominal pain. They have some abdominal pain. And so these kinds of things are making me think that this patient has the perfect absolute picture for polyarteritis nodosa. So what else could help me in this? The other thing that's helpful is the fact that they came back positive with hepatitis B virus and they came back negative for ANCAs.
Right.
So if you come back negative for ANCAs, it tells me that it's unlikely an ANCA-associated vasculitis. And this patient doesn't really fit the picture of any kind of like immune complex vasculitis, which we'll talk about kind of last. So right away, I'm not thinking ANCA and I'm not thinking immune complex based upon the presentation. So what I'm left with is my median vessels, which is polyarteritis nodosa or Kawasaki's. This is definitely polyarteritis nodosa. What would pretty much nail or cement the diagnosis is the angiography for me. So that would be enough for me. If I see multiple microaneurysms of the mesenteric vessels, the renal vessels, and even sometimes you can see it in the hepatic vessels, that's really good. If you have those clinical features, hepatitis B virus infection, and on top of that, angiography, visceral angiography, you're good. If you can, let's say that a patient has some type of like palpebral purpura or a levator reticularis or nerve involvement, I would take a biopsy from that piece of skin and go down deep enough to hit some nerve and take that piece. And if I got fibrinoid necrosis that showed that, is gold standard.
Yeah.
But not all patients will be able to get that biopsy, and you have to kind of weigh the risk versus benefit of doing a biopsy. And this patient, if it's skin or if it's nerve, that's okay. But any other kind of organ, you're taking a little bit of a risk. This right here, perfect case for polyarteritis nodosa, though.
And all being underneath the umbrella of a medium vessel vasculitis.
Yep, exactly.
Okay. Alrighty. So how do we treat this patient?
So I think there's always a bunch of different ways that you could do this. You could, again, probably nuke them with steroids or something. But, oftentimes you'll get lucky if you pick vasculitis and you pick the treatment. Steroids, you can't go wrong with them because you're trying to suppress, a massive amount of inflammation. For the way I look at polyarteritis nodosa is I ask myself the question, do they have significant organ involvement that could cause death? What do I mean? Is it hitting the kidneys? So do they have kidney injury? So like, is there a bump in their creatinine? Is there a drop in their GFR? Is there an increase in their BUN? Is their hypertension significantly uncontrolled? Do they have GI involvement, like mesenteric issues, like mesenteric ischemia with lots of pain, mononeuritis multiplex where they're having nerve involvement? That's affecting quality of life. In those scenarios, I would not hesitate, and I would give them steroids and another drug, which is really strong, called cyclophosphamide. And that's going to really kind of dampen down the inflammation. If they have just like skin involvement, some constitutional symptoms, I may not be as aggressive in throwing on that cyclophosphamide, and I might just do steroids. But oftentimes, if I have multi-organ involvement, don't waste time, steroids and cyclophosphamide.
And then he does have hepatitis B. He's not being treated for it. So then you would also treat that as well.
Yeah, that's the thing, because you can suppress the inflammation, but you're going to have recurrence if you don't treat the underlying cause. And so for this patient, it's hepatitis B virus that's likely triggering it. Now that we got the test, treat them for it, and hopefully that'll reduce the recurrent episodes of their continued inflammation.
All right. Well, let's move on. Case 4. We have a youngin'.
Yeah.
We have a young one.
Yeah.
Parents bring a 4-year-old boy to the pediatric clinic with a high fever and rash. Based upon just history alone, you could probably already narrow it down.
Yeah. There's not many like childhood vasculitides.
Yeah.
There's really only 2, but I have a feeling I kind of know which one it is right off the get-go.
So for this child, he has a high fever, temp of 104 Fahrenheit for the past 6 days. It has not responded to acetaminophen. The parents report that he has been irritable and not eating well. They also noticed a rash that began on his trunk and is now spread to his limbs. Additionally, they report that his eyes have been red, his lips cracked and swollen, and his tongue has become red and bumpy. The child has also complained of pain in his hands and feet. As we know from his history, he does have a fever. Currently, vitals, temperature is 103.5 Fahrenheit, heart rate is 140, respiratory rate is 24, blood pressure is 95/60, and SpO2 is 99% in room air. For his exam, skin is polymorphous rash involving the trunk and extremities, desquamation of the skin on hands and feet. Oropharyngeal, cracked, red lips. Also, we note a buzzword term here, strawberry tongue.
Yeah.
Eyes, bilateral conjunctival infection without exudate. Neck, non-purulent cervical lymphadenopathy, 1.5 centimeters in diameter. MSK, swelling and erythema of hands and feet. For lab testing, we get a CBC back. The white count is 18,000. Platelets are 550,000. ESR is 85. CRP is 12. And liver function tests are mildly elevated. Imaging and additional tests, we get an echocardiogram. An initial echocardiogram is used to evaluate for coronary artery abnormalities, which shows mild dilation of the right coronary artery. So, Zach, we know we have a young patient here, a lot of pretty nasty stuff going on.
Yeah.
What do you think is going on? What type of vasculitis? And then how do you approach it?
Yeah, so this is a pediatric patient who seems like they have Kawasaki's disease. So Kawasaki's is kind of one of those diseases that you can pick up based upon a patient having what's called the crash and burn features. So C is the conjunctivitis, or the kind of involvement of the conjunctiva where they're, as you said, very injected. So they're red, they're hyperemic. The other thing is I'm looking for particularly like rashes. And so this patient has a polymorphous rash that's present all over their trunk and extremities. That's a big one. A is for adenopathy, so lymphadenopathy. So they have some cervical lymphadenopathy that's going on there. They were even kind enough to give us the diameter of that, which is crazy. And then on top of that, we also see the S for the strawberry tongue. So we see that they have the cracked red lips with the strawberry tongue. And then H is they have hand and foot edema and erythema. So swelling and redness of the hands and feet. So that's the crash part of that buzz term. And then there's the burn. So crash and burn is the fever. Fever lasting greater than 5 days. This patient's around 6 days of having a fever. So when I notice that crash and burn features, conjunctivitis, rash, adenopathy, strawberry tongue, hand and foot edema, erythema, as well as a fever greater than 5 days, it kind of tells me that it's a high likelihood of Kawasaki's disease. At that point, you can pretty much make the diagnosis, and then you're going to start them on the appropriate treatment. What's nice about this is that you gave me their initial echocardiogram. And the reason why is when I have a patient who has Kawasaki's disease, the way that we treat these patients is we start them on IVIG, which is going to hopefully reduce a lot of the inflammation. Because what happens with Kawasaki's disease is it likes to target the coronary arteries. And so this is the one that can kill the patient because it'll cause the coronary arteries to get dilated and form aneurysms. They can thrombose and cause a heart attack, an MI in these patients, or they could rupture and lead to sudden cardiac death via disastrous arrhythmias. And so in this patient, I want to give them IVIG because it's going to reduce the inflammation and reduce the risk of those aneurysms forming or getting worse. And then give them aspirin to prevent thrombosis within those aneurysms. The big thing is how you set me up with this is that I'll start that treatment and then I'll check an echocardiogram in maybe like 2 weeks or 6 weeks and look to see what's going on with those aneurysms. Are they getting bigger? Ooh, if they are, I got to keep a closer eye on that. Are they staying the same? Good. I can check at the next interval couple weeks. And so I think that's the really important thing is to be able to know this patient's Kawasaki's, but more importantly, how do we treat them and what are we monitoring for closely to make sure that their risk of mortality doesn't go up?
So basically for this patient population, an echocardiogram is critical.
Yeah, it's very important.
All right, let's move on to case 5.
All right.
We have a 45-year-old male, presents to the clinic with complaints of nasal congestion, bloody nasal discharge, and worsening shortness of breath over the past 3 months. The patient reports experiencing persistent nasal congestion and recurrent episodes of sinusitis for the past several months, which has not improved with multiple courses of antibiotics. He also notes a bloody nasal discharge and occasional epistaxis. In the past month, he has developed a productive cough with occasional hemoptysis and increasing shortness of breath on exertion. He has also noticed generalized fatigue, weight loss, and joint pains. Past medical history, recurrent sinusitis. Let's move into vitals. Temperature of 37.8 Celsius. So he does have a fever, or just about a fever at 100 degrees Fahrenheit. Blood pressure is 140/85. Heart rate is 95. Respiratory rate is 22. And SpO2 is 96% on room air. For his exam, ENT exam, nasal mucosa is erythematous with crusting and ulcerations. Respiratory, there's bilateral crackles in the lower lung fields. Musculoskeletal, tenderness in multiple joints without swelling, and skin palpable purpura over the legs.
Gotcha.
So for some lab testing, we have a CBC, hemoglobin of 11, a white blood count of 14,000, and platelets of 400,000. ESR is 100, CRP is 15, serum creatinine is 1.9. We get a urinalysis. We do notice that there is hematuria, proteinuria, and red blood cell casts. We do get an ANCA back, and we see that it's positive for C-ANCA,
Okay.
a PR3 ANCA.
Gotcha.
All right. Last thing, we get some imaging done. We do get a chest x-ray because of the lung field, the crackles in the lower lung fields. And we notice multiple bilateral nodular opacities with cavitation.
Okay.
All right.
This guy has so many terrible things going on.
Yeah, I can see that.
Feel very, very bad for this gentleman.
So what do we have to do then?
So right off the get-go for this one, I'm definitely suspecting, again, kind of an ANCA vasculitis. The type, it seems like what's called Wagner's granulomatosis with polyangiitis. So that's what I'm definitely suspecting is it's kind of like one of those particular types of diseases. Now, the reason why is when I look at this patient, the first thing I notice is, again, elevated ESR, elevated CRP. They have some constitutional symptoms with some generalized fatigue, weight loss, and joint pains. Then when I go to the kind of small vessel vasculitides, the way I kind of diverge them into immune complex versus ANCA is a particular triad. If a patient has glomerulonephritis, they have palpable purpura, and they have pulmonary involvement, those three things kind of cue you in to think about this is an ANCA vasculitis. And when I look at this patient, what do I notice? I notice that the patient has pulmonary involvement via the bilateral crackles, the occasional hemoptysis, the shortness of breath on exertion. I notice that they have skin involvement via the palpable purpura over both legs. And then on top of that, I notice the glomerulonephritis based upon the urinalysis showing me hematuria, proteinuria, and red blood cell casts. So this patient, and the serum creatinine is 1.9. I don't know what the baseline is, but I'm suspecting that it's a little bump there. So they probably have an acute kidney injury combined with that. So the glomerulonephritis, the pulmonary infiltrates with hemoptysis, and the palpable purpura tell me it's an ANCA vasculitis. And then When I move to the next point, which is an ANCA, I have to figure out which of the three types of ANCA vasculitides is it? GPA, EGPA, or MPA. One of the first ways I can do that is by checking an ANCA, but checking for a type of ANCA. For example, in this one, I see C ANCAs are positive. If a C ANCA is positive, that really almost always tells me that it's GPA. So from there, I think one last thing. Is there any specific characteristics that highlight GPA as compared to EGPA or MPA? And the one thing that does that is the initial presentation, which is the nasal congestion, the bloody nasal discharge, and on top of that, the recurrent episodes of sinusitis with occasional epistaxis.
So being that there's definite nasopharynx involvement.
Exactly. That tells me that this is likely GPA. So with that being the case, I can kind of pretty much for the most part have a very, very strong suspicion of GPA. I don't need to get a biopsy, but if I really wanted to guarantee it, I could do a biopsy. You could do a renal biopsy. You could do a skin biopsy. You could do a pulmonary biopsy, but I would try to do a biopsy to find that there is evidence there, particularly of granulomatous inflammation. So when I check it, I'll see these cavitating granulomas. That would be the definitive diagnosis, but I think off of the ANCAs, the clinical involvement, ESR-CRP, I think I have enough to kind of make the diagnosis of GPA.
All right, let's go into case 6 now. We have a 35-year-old female, presents to the clinic with complaints of worsening asthma, sinus pain, and new skin rashes over the past 3 months. The patient reports a history of asthma that has been worsening over the past few months, requiring frequent use of her inhaler. She also describes persistent sinus pain, nasal congestion, and recurrent sinusitis episodes. Over the last few weeks, she has developed painful red nodules on her legs. She also mentions generalized fatigue and weight loss. Past medical history, asthma, diagnosed 10 years ago, and allergic rhinitis. Vitals, we have blood pressure is 130/80. Temperature is 37.5 Celsius, so that's a little high, 99.5 Fahrenheit. Heart rate is 90. Respiratory rate is 20 per minute. Oxygen saturation is 98% on room air. For her physical exam, for a skin exam, we note palpable purpura and tender nodules on the lower extremities. ENT, nasal mucosa is erythematous with mild crusting. And for her respiratory, bilateral wheezing on auscultation. Lab testing, we get a CBC and we see eosinophilia. Eosinophil is 25%. Erythrocyte sedimentation rate, ESR, is 90. CRP is 10. Serum creatinine is 1.6. Urinalysis, we have hematuria, proteinuria, red blood cell casts. We get an ANCA back, and it is a positive now for a P-ANCA. IgE levels are significantly elevated. Imaging and additional testing, we have a chest x-ray, bilateral patchy infiltrates. Skin biopsy shows eosinophilic infiltration and necrotizing granulomas in vessels. So, Zach, what do we have to do here for this patient?
So same thing. It kind of sounds like an ANCA vasculitis because I have the pulmonary involvement via the pulmonary bilateral infiltrates. I also have skin involvement via the palpable purpura, and I have glomerulonephritis via the hematuria, proteinuria, red blood cell cast, and potentially some kidney injury via the slight bump in creatinine if this is above her baseline. So right there, I have the triad or the trio that suggests an ANCA vasculitis. From there, I'm going to then move on to say, okay, which type of ANCA is it? You told me that it's a P ANCA. If it's a C ANCA, there's only one likely cause, and that's going to be the GPA. If it's P ANCA, it could be MPA, which is kind of like your microscopic polyangiitis, or eosinophilic granulomatosis with polyangiitis, so EGPA. So then from there, I have to think, okay, what kind of things would make me highlight the confidence of EGPA as compared to MPA without me having to go to a biopsy? And so a couple things. One is that usually patients who have EGPA, before they proceed to the vasculitis stage where they have palpable purpura, before they have glomerulonephritis, and even sometimes mononeuritis multiplex, they oftentimes precede that vasculitic phase with eosinophilia that kind of also presents with what's called allergic asthma and allergic sinusitis. So this patient has some sinusitis, probably allergic related, and on top of that has asthma that's getting a little bit worse lately, likely allergic and in this case, eosinophilia related. So when I see asthma, allergies, and they're kind of like worsening, they're new onset, that definitely makes me think EGPA. The other thing that makes me think EGPA is two other concepts. Something that drives up the allergies and drives up the asthma is an increase in eosinophils, because eosinophils are a very, very potent driver of asthma. And on top of that, IgE levels. IgE levels are kind of a marker of systemic kind of allergies. And so I see that this patient has elevated IgE levels, and on top of that has elevated eosinophil levels. That right there is kind of like, for me, enough to say that this is likely EGPA. If I wanted to go further distance and say, all right, how do I guarantee this is EGPA? Then I could do a biopsy. And if I obtain the biopsy, which this patient already had, it would show lots of eosinophils, but more importantly, it would cause necrotizing granulomas. And that's what's really important, because in MPA, you won't see any sinus involvement. You will not see any eosinophilia. You will not see any types of particularly elevated IgE levels, and you won't see any necrotizing granulomas in their vessels. And so that's the way that I would kind of evaluate this patient.
So big difference then, EGPA, GPA versus MPA could be the granulomas plus a C ANCA or a P ANCA.
Exactly. That's the big way of being able to diverge from that point of ANCA vasculitis. Is it C or P ANCA? And if it's C, it's GPA. If it's P, it's MPA or EGPA. Then from there, which ones have granulomas?
Gotcha.
GPA, EGPA, which one doesn't? MPA.
Cool. All right. Case 7. We have a 50-year-old male presents to the clinic with complaints of fatigue, hemoptysis, and hematuria over the past 2 months. The patient reports feeling increasingly fatigued over the past few months. He recently developed a cough, a productive cough, blood-tinged sputum, and has noticed dark-colored urine. He denies any fever, night sweats, or weight loss. He also mentions mild joint pains, but no significant swelling.
Okay.
Vitals. We get a temp back, 37.4 Celsius, mildly elevated. Blood pressure is 145/85. Heart rate is 88. Respiratory rate is 20. And SpO2 is 97% of room air. For his physical exam, respiratory, there is bilateral crackles in the lower lung fields. And for his skin, there's palpable purpura on the lower extremities. For some lab testing, we get a CBC, hemoglobin is 10.5, ESR is 90, CRP is 10, serum creatinine is 1.7. We do get a urinalysis. We have hematuria, proteinuria, red blood cell casts. And then we have an ANCA. This comes back. It's positive for P ANCA. Imaging, we have a chest x-ray showing bilateral patchy infiltrates and a skin biopsy. The skin biopsy shows no necrotizing granulomas. So based upon what we just talked about, you can probably kind of guess what this one's going towards.
Yeah, exactly. This one's kind of setting you up for the last one, which is MPA. And we can kind of deduce that by the triad of pulmonary via hemoptysis and the pulmonary infiltrates, hematuria with the red blood cell casts and proteinuria via the glomerulonephritis, and then the palpable purpura, which is the skin lesions. From there, ANCAs. What's the ANCA? It's P ANCA, so it's either EGPA or MPA. I don't have any sinus involvement. I don't have any eosinophilia. I don't have any elevated IgE levels. No asthma, allergy involvement. From there, I could suspect it's MPA, but if I needed to guarantee the diagnosis, I could get a biopsy and it'll show no necrotizing granulomas. So yeah, this one's a perfect setup for a patient who has MPA.
All right. Pretty straightforward.
Yeah. And I think that's a great thing to also highlight, is that whenever you get a patient who has an ANCA vasculitis, oftentimes you may be stuck in a kind of a scenario here where you're trying to say, all right, well, how important is it that I know which one is which? Is that going to change the treatment for this patient? And no, it might not really change the treatment in these patients. They might all actually end up being the same, but I think it's important to understand which one it most likely is. But in the grand scheme of things, if you guess wrong, guess what? The treatment's pretty much all the same for these.
Pretty much steroids.
Yeah, and so that would be a big one. So for example, let's say that I have a patient who I suspect has an ANCA vasculitis, and let's say that they don't have any really bad glomerulonephritis, because what can happen is glomerulonephritis can rapidly progress and cause like acute kidney injury to the point where a patient needs hemodialysis. And that's called RPGN, so rapidly progressive glomerulonephritis. Another thing is that sometimes patients can have significant pulmonary infiltrates or a lot of bleeding that can occur inside of their alveoli, that it causes diffuse alveolar hemorrhage, which can cause ARDS or cause massive hemoptysis. And that's also very, very deadly and dangerous. In those two scenarios, I'd be super concerned if a patient has features of ANCA vasculitis and they have RPGN and diffuse alveolar hemorrhage. The other thing is that when a patient has hemoptysis and hematuria, You always have to have a differential, something called good pasture syndrome, which is anti-GBM disease. In those three scenarios, if I have any concerns, they have RPGN, so rapidly progressive glomerulonephritis, meaning they have hematuria, proteinuria, red blood cell cast, and a massively increased creatinine, I'm going to start them on something called Plex. If they have diffuse alveolar hemorrhage where they're developing ARDS, they're having lots of hemoptysis, I'm going to start them on Plex. And if I have any suspicion that they could have good pasture syndrome, I'm going to start them on Plex. The whole point of Plex is it's a kind of a plasma exchange, is you're trying to remove a lot of those antibodies, those ANCAs or anti-GBM antibodies, out of the circulation to reduce the progressive damage. If they don't have any of those things, in other words, they do have glomerulonephritis, but it's not rapidly progressive, they do have pulmonary infiltrates, but it's not diffuse and having ARDS, and you don't have no suspicion of anti-GBM disease, you can just start steroids and cyclophosphamide to really suppress this kind of disease. So that's the way I would treat these patient populations.
All right. So case 8, we have a 6-year-old boy is brought to the pediatric clinic by his parents due to a rash, abdominal pain, and joint pain. The child has had a purpuric rash on his legs and buttocks for the past 3 days. He also complains of intermittent abdominal pain, which is crampy and it worsens after meals. Additionally, he has been experiencing pain in his knees and ankles. His parents note that he had a mild upper respiratory infection about a week ago. He has no history of recent medication use, and his vaccinations are all up to date. Vitals, we have a temperature of 37 Celsius, so normal. Blood pressure is 100 over 60. Heart rate is 90. Respirations is 18 per minute. And SpO2 is 99% on room air. For his physical, his skin, there is palpable purpura on the lower extremities and buttocks. Abdominal, mild tenderness to palpation in the lower quadrants. No rebound tenderness or guarding. MSK, swelling and tenderness of the knees and ankles with limited range of motion due to pain. Lab testing, we do get a CBC back, hemoglobin of 12.5, a white count of 11,000, and platelets 350,000. Serum creatinine of 0.4, which is normal for his age. Urinalysis, microscopic hematuria, and mild proteinuria. And then we have a serum IgA, which does come back elevated. For some additional imaging, we have an abdominal ultrasound showing no evidence of intussusception or other abnormalities. And then we do have a skin biopsy. With the skin biopsy, we notice leukocytoclastic vasculitis with IgA deposition in the vessel walls.
It's a mouthful.
Whew,
Right?
that is a mouthful, and a lot of stuff going on with this
Yeah.
poor patient.
Yeah.
So how do we go ahead and approach this one then?
I think for this one, again, it's a young patient. So there's really two childhood vasculitides. One is Kawasaki's, and the other one is IgA vasculitis. They both can present with rashes, right? But I think the big difference that kind of tell me which one is which is if I have a patient who presents with a purpuric rash on his legs and buttocks. Mm-hmm. That's pretty telling, but even more telling than that is when their presentation or their chief complaint or the reasons why they're coming in to seek care is actually followed by a recent upper respiratory tract infection. Oftentimes, group A beta hemolytic is streptococcus infection, so strep throat's a very common offender, but any viral infection of any sort can oftentimes be a very primary trigger. Because what happens is this pathogen is trying to generate an immune response. Your immune system will generate IgA antibodies, but these IgA antibodies will attack your actual blood vessels and other tissues, unfortunately, because the proteins on the bacteria or virus mimic some of the proteins in the vessel walls. That's the problem here. So for this young child, I see a couple things. A triad is usually the big one. One is the purpuric lesion. So he has palpable purpura on the lower extremities and the buttocks. That's a characteristic kind of presentation of it. Second thing is the joint pain. Whenever they're having lots of joint pain, that's a very common one. And the third thing is microscopic hematuria. So we can oftentimes define this as glomerulonephritis if there's red blood cell casts. So those three things make me think about what's called immune complex vasculitis. What I then want to do is I want to determine, is it IgA vasculitis or is it cryoglobulonemic? For this thing, history is usually going to be enough, but what I'll do is I'll check an IgA level, a cryoglobulin level, and a C4 level. If I check that, generally the cryoglobulins will come back negative. You won't have any. You'll have a normal C4 level and an elevated IgA level. And that right there will tell me that this patient likely has some type of IgA vasculitis potentially.
Especially in our patient, which the serum IgA was elevated.
Exactly. Plus, they have the presentation of having this prior upper respiratory tract infection recently. So that's a telling sign. I don't necessarily need to get a biopsy in these patients. And if anything, you increase the risk of harm, especially since you would possibly need a renal biopsy. So I personally wouldn't go that route, and I would treat this patient supportively. However, if we did obtain a biopsy, it would show lots of white blood cells that are depositing in the vessel wall along with some IgA antibodies.
So are we going to be following our recurrent theme of prescribing steroids, or are we going to be looking for an alternative care?
Yeah, that's a good question, because oftentimes with these patients who have IgA vasculitis, or also termed Henoch-Schönlein purpura, the best thing to do is just to do supportive care. There's some evidence that actually says you could use steroids, but oftentimes it's not necessary. It's best to just treat their pain if they have any joint pain or if they have any fevers. Generally, NSAIDs are going to be kind of the agent of choice here. But sometimes you can consider steroids. I would say the only time where that should be considered is if they have a very severe glomerulonephritis. Oftentimes, though, IgA vasculitis will not cause that severe of a glomerulonephritis. But that would be one potential indication. But oftentimes, more than not, supportive care is the way to go for this patient population.
Okay. Last case, guys. Here we go. Stick with us.
All right.
We have a 55-year-old female presents to the clinic with complaints of fatigue, arthralgia, and a new rash on her lower extremities. The patient reports a 3-month history of progressive fatigue and joint pain, particularly in her hands and knees. She also noticed a purpuric rash on her lower legs that appeared 2 weeks ago. She describes episodes of numbness and tingling in her fingers and toes. She has a history of chronic hepatitis C, but has not been on treatment for the past year. Some vitals. We have a temperature of 37.2 Celsius, a little bit elevated. Blood pressure, 130/80. Heart rate, 88. Respiration, 16. And SpO2, 98% on room air. For her physical exam, skin, we do note palpable purpura on the lower extremities. MSK, there is tenderness and mild swelling of the small joints of the hands and knees. And for her neuro exam, there is decreased sensation to pin, prick, and light touch in the glove and stocking distribution. For some lab testing, we get a CBC back, hemoglobin's at 11, white count at 10,000, platelets at 200,000. Serum creatinine, 1.3, C4 complement, low, rheumatoid factor, positive, cryoglobulins, positive. And then we do test the hepatitis C RNA, and there is a detectable viral load. A little bit more, we do a skin biopsy as well, and we come back with that mouthful of leukocytoclastic vasculitis with cryoglobulin deposits in the vessel walls. Whew. Another tough patient case here, but it does seem pretty textbook. Where do you go from here?
It's the same thing. Suspect immune complex vasculitis via the joint pains, the evidence of glomerulonephritis, it seems, based upon potentially their presentation. And then on top of that, I also see the purpuric lesions. So when I see the purpuric lesions, the joint pain, and the potential, glomerulonephritis, that makes me think it's an immune complex. What I would do is I would do the same thing. I get a cryoglobulin, I get an IgA, and I get a C4 level. When a patient has cryoglobulin vasculitis, oftentimes there's 3 types. There's type 1, which we see in multiple myeloma, where they have lots of IgM antibodies that they produce, and they're usually monoclonal. Type 2 is usually the most common one, and this is the one that usually causes vasculitis. Type 1 doesn't usually cause vasculitis. It causes more of what's called a hyperviscosity syndrome. But type 2 is usually associated with hepatitis C virus infections, and that's a telltale sign. So if I see a patient who has hepatitis C virus infection, that's usually a very common offender of generating these weird antibodies. One of the antibodies is an IgM antibody, and it's actually referred to as rheumatoid factor. And if you look, their testing comes back with a positive rheumatoid factor.
Yep.
That probably means that they have lots of IgM. But the other thing is that they generate what's called IgG polyclonal antibodies. What happens is the IgG polyclonal antibodies and the IgM rheumatoid factor antibodies precipitate and bind together. And whenever they bind together, they can precipitate and form these complexes only when the temperatures get to like less than 37 degrees Celsius. That protein that precipitates the IgG and the IgM is called cryoglobulins. And so that ends up being positive in this patient because they have the rheumatoid factor, they have the polyclonal IgG antibodies, and that's what's kind of complexing. And those proteins are depositing in the blood vessels and causing all this injury. So that right there would be an answer. positive cryoglobulins, positive rheumatoid factor, and the C4 proteins are low. The whole concept behind this is that once the antibodies bind on to their target, they activate the complement proteins to bind onto that antibody portion and trigger membrane attack complexes, opsonization, all kinds of white blood cells come to the area. Leukocytes come in, they start really damaging the blood vessels. So the fact that they consume the C4 proteins and it's low adds to the diagnosis of cryoglobulonemic vasculitis. Last thing I could say is if I really, really wanted to, I could go ahead and get a biopsy. I don't think it's necessary in this patient. I think that we got a good answer. But if I did, which this patient has, you'll see a lot of those cryoglobulin deposits, the IgG, the IgM, and the C4 proteins deposited into the vessel wall, along with lots of white blood cells that are there as well. So that would really be the answer to this one, would be the cryoglobulonemic vasculitis.
All right. So with treating cryoglobulonemic vasculitis, what are you going to do for that one? And then at what point do you decide we have to, give her treatment for her hepatitis C?
That's a good question. So I think for this patient, right away, whenever you're trying to analyze a patient who has cryoglobulonemic vasculitis, you just have to ask yourself the question, do they have something? Because joint pain, yes, that sucks. I'm sorry, but it's not life-threatening. Palpable purpura, it sucks, but it's not life-threatening. Glomerulonephritis can be life-threatening.
Okay.
Because it can progress to acute kidney injury. So if a patient has glomerulonephritis with lots of hematuria, proteinuria, rise on their creatinine, urine outputs trailing off, that's something that I would say, I got to treat this patient. I probably put them on steroids and cyclophosphamide. An alternative only in this one is treating them with rituximab, but oftentimes steroids, cyclophosphamide is the option. If they don't have glomerulonephritis and they just have joint pain or skin lesions, I'm not as worried, and I could probably just do supportive care. Treat the joint pain, let the skin lesions go away, and treat the underlying cause. Either way, if you're giving a patient steroids and cyclophosphamide, you better be treating the underlying cause. If you're doing supportive care, you better be treating the underlying cause. And that's the hepatitis C virus infection. I have to treat that. And once I treat that, that'll reduce the risk of recurrences and the constant inflammation that occurs in these cycles.
All right. 9 cases on vasculitis. Somehow we did it. That was a lot, but somehow it didn't seem all that bad.
No, I think a lot of it's repetitive, right?
Yeah,
so
it was.
You're kind of generating the same diagnostic schema throughout every single scenario. And I think that's the point, is that it seems like a lot, but it actually is not. When you truly put all of this stuff together into kind of one algorithm, you can generate a good approach into how to really figure out which type of vasculitis it is. But on top of that, figure out when do I treat it, and specifically, what are the treatments?
Are you up for a real quick summary?
Yeah, let's do it. So I think one of the big ways of being able to think about these is, again, every patient who comes in with a suspicion of vasculitis, check the ESR CRP. If it's elevated and they have constitutional symptoms, have some degree of suspicion. From there, I think that determining the type of vasculitis depends upon the clinical presentation. For example, if I have a patient who comes in, they have temporal headaches, they have tenderness over the area, they have vision changes, they have jaw claudication, elevated ESR CRP, I'm thinking giant cell arteritis. Confirm with a temporal artery biopsy. If they come in less than 50 years of age, Asian descent, they have unequal blood pressure and pulses, maybe they have a bruit over that affected area, some syncope if they have some carotid involvement, and an MRA that suggests narrowing of the actual aorta and its branches, Takayasu's.
Okay.
Next, if I have a patient who comes in and they have a history of hepatitis B virus infection, mononeuritis multiplex, which is the multiple mononeuropathies, consistently elevated high blood pressure, so hypertension, maybe some CKD in there as well, plus levita reticularis or some type of palpable purpuric lesions.
Yep.
That would make me think about polyarteritis nodosa, especially if I see on their visceral angiography that they have some renal artery microaneurysms, some mesenteric artery aneurysms. That would be pretty good for me. And a biopsy that shows fibrinoid necrosis via skin or nerve would seal the diagnosis. For Kawasaki's disease, for this one particularly, I'd be thinking about a patient who's young, so pediatric population. The big thing for this one, I'm looking for that crash and burn features. So in other words, I'm looking for conjunctivitis. I'm looking for that polymorphous rash. I'm looking for adenopathy. I'm looking for strawberry tongue. And I'm looking for, again, hand and foot edema and erythema. Followed along with a fever that greater than 5 days. Big thing for this one, there are super high risk for coronary artery aneurysms. You need to be screening for those with very frequent echocardiograms. Okay. From then, I would move into your small vessel vasculitides, so your ANCAs. That one, I'm looking for pulmonary involvement, glomerular involvement, and skin involvement. So palpable purpura, hematuria, and hemoptysis, or some type of pulmonary infiltrative involvement. From there, if I make that suspicion of those three, I check the ANCAs. If the ANCAs come back C ANCA, it's likely GPA, especially if nasopharynx involvement. If it comes back P ANCA, it's potentially EGPA or MPA. From there, if I have elevated IgE, eosinophils, allergic involvement, from there, I'm suspecting it's EGPA. If I don't know, I can obtain a biopsy, and a biopsy will tell me if I see necrotizing granulomas, it's GPA, EGPA, and if I see no necrotizing granulomas, it's MPA.
Okay.
Lastly, if I see joint pain via joint involvement, palpable purpura and glomerulonephritis, so hematuria, proteinuria, red blood cell cast, I'm thinking about immune complex vasculitis. From there, I'll check an IgA, cryoglobulins, rheumatoid factor, and a C4 level. If it comes back, no cryoglobulins, normal C4, elevated IgA level, I suspect IgA vasculitis. On top of that, if they had a recent upper respiratory tract infection, again, nails pretty much the diagnosis of IgA vasculitis. If I need to go the extra step, it's more risky than it is beneficial. You can obtain a biopsy and it'll show lots of IgA deposits with leukocytoclastic vasculitis. For a cryoglobulinic, I would see positive cryoglobulins, positive rheumatoid factor, a decreased C4 level, and normal IgA levels. From there, I suspect cryoglobulinic vasculitis. I don't need to, but if I wanted to, I could get a biopsy. But if I have a patient with a hepatitis C virus infection, that's more suggestive than the biopsy. If I get the biopsy, it'll show leukocytoclastic vasculitis with IgG and IgM deposits along with C4 complement proteins. That's how I would diagnose it, and then treating them, for the most part,
Steroids.
Exactly. If you make that guess, you're likely right. The only times you'll add in another agent is for polyarteritis nodosa, you'll add in cyclophosphamide. For your ankylvasculitides, you'll add in cyclophosphamide. And then the other scenario is your Plex. That's really only going to be for the ankylvasculitides that are accompanied with RPGN, diffuse alveolar hemorrhage, or suspicion of Goodpasture syndrome. And I think that would give you guys everything you need for vasculitis.
It's a beautiful summary.
Thanks, man.
Beautiful summary.
That.
If you guys want more of this stuff, you could become a premium member on our website, ninjanerd.org. We have notes, illustrations, we have quizzes, everything to test your knowledge, helping you to learn as much as you possibly can. Please check it out.
Yeah, and I know I'm probably biased in saying this, but again, if I was a student and I was going through this like you guys are, I would definitely be purchasing these, because I'm telling you, and I'm truly being honest with you, there's so many benefits to getting a membership. You'll have videos, you'll have great notes to follow along with, illustrations to really help get the point across. And then a really big factor that we're working really hard on is question banks to test your knowledge on that topic. So definitely check that out. I really think that it'll make a big difference in your academic endeavors. But nonetheless, that covers vasculitis. I really hope that you guys liked it. I really hope it made sense and that you guys did enjoy it. And love you guys. Thank you guys. And as always, until next time.